Welcome everybody to another Couple Nurses episode number 115. And remember, make sure you follow us on YouTube, check out our vlogs, check out our episodes. We're live everywhere. We're technically not live, but we're on every platform: Spotify, Apple Podcasts, YouTube. We were on Patreon for a bit, but we took that off. But yeah, make sure you give us some good ratings. Some comments are always appreciated. Let us know what you like. Let us know what you dislike, what ways we can improve, and don't forget our website, couplenurses.com. So what are we talking about today, Matt?
So on today's episode, we're going to talk about everything end of shift. How to end your shift, how to make that awesome note because it matters, and everything that comes to giving good report when it comes to end of shift. So you know that anxiety or that time like, oh damn, I have to wrap up the shift. How's my patient doing? Did I turn my patient? Are all my drips good? Did I do all the orders? What am I missing? What were my outputs? Like you have all these questions running through. And I think it really matters as a nurse to have a solid end of shift.
Yeah, it's also one of those things where you're going to improve on it gradually, especially as a new grad. You're not really going to know what key points to highlight. So I like it. If you're a new grad, always try and keep it short and to the point until you realize what things you have to add onto it, and then you can kind of expand.
Yeah.
But try to at least nail all the systems, all the subgroups in just like a narrow, streamlined fashion. Because we don't really have time to ask you or teach you on the spot every time. So just keep it short and sweet, and then your fellow seasoned nurses will always give you some good feedback, good constructive criticism on how you can improve and what to add.
Exactly.
And you'll also get a report back, so you could also pass on the things that you enjoyed hearing during your report. So if you're hearing something like hourly outputs, every report you're not giving hourly outputs, then maybe you should probably start giving hourly outputs.
You make a very good point. You learn by mimicking behavior. And a normal report should last anywhere from 5 to 15 minutes, all depending on what specialty you work in. I think in the ICU it takes about 10 to 5 minutes. If I'm coming back, it's under 5 minutes to 5 minutes. I'm giving pretty brief details of how my shift went, the tests that I did, procedures, what did a doctor say roughly based on consultations, any kind of medications I would change, the plan of care, and anything else.
Yeah, mine I would say probably is anywhere from 10 to 15 minutes. I time myself the last times, and usually if somebody comes on, like last time I timed myself, the night shift nurses came at like 7:06, and I got done with the report at about 7:26, so about 20 minutes roughly. So it's like 10 minutes per patient.
Yeah, and if you think about it, in this hospital we work at currently, night shift gets on maybe at 7:05 p.m. because there's always a huddle. And we usually leave no later than 7:35, 7:30. So you're looking at about 25 minutes for 2 patients in the ICU, get everything done, laugh around, and just leave. So it's pretty efficient.
Yeah, straight business.
And you have those mid-shift nurses, you feel like you can't wrap up your shift, you have some charting to do. You could call them over. Hopefully, it's not a busy shift, and they could kind of cover some regular patient care, and you could get that done.
Yeah, and every nurse always asks this question last. Hey, are you back tomorrow? They always ask that at the end because if someone is back tomorrow, then you're going to give a short report, probably like 5 minutes, and then you're out of there. So it's always so convenient, so clutch to have the same nurse come relieve you as you've gotten a report from.
And I feel like that question is so much more valuable on night shifts because as a day shift nurse, you kind of know the synopsis of what's going on. You rounded it with the doctors, essentially. On nights, whatever happened yesterday is just word of mouth from the day shift nurse. So you kind of have to say the same thing because that day shift nurse will ask probably very specific questions depending on the nurse.
Yeah,
so I always had that thing like, damn, let me read these consultations because I have no idea what's going on. You have those busy shifts like, damn, I didn't read a single note.
Yeah, definitely. On nights, it's a big thing reading notes. I read my notes on days, but I've definitely read more notes on nights than I have time for on days. But first things first, when you give a report, is always make sure the patient assessment is still updated and accurate from the prior assessment. So check on your patient. That comes first before you even give a report. The next nurse is coming on. You have to make sure your patient's squared away, make sure his vitals are good, blood pressure is at an appropriate level. Are they tachy? Are they hypotensive? What's going on? Do you have any kind of signs and symptoms? Has the urine output dropped in the last couple hours? Like what's going on? You want to square your patient away so you're giving them at least a stable and decent starting point for the shift to come.
Yeah, and always prioritize them and make them smile, make them feel positive because that anxiety that you relieve from the patient, that trust that you build, I always tell them, you have any anxiety, any stress, situations, questions, leave all the worrying to me. That's why I'm the nurse. And they always have that sense of trust from me. And I feel like that makes my shift easier because they have less questions, less like, that whole fear thing of what's the plan of care.
Right. And a good rule to always go by is to square away your patient by, I'd say, 6 o'clock. If your shift ends at 7, square them away at 6. That means you're not going to change or adjust anything after 6 p.m. that has a potential to change your patient status. So at 6 o'clock, I'm not titrating any more drips. If the patient's hanging out and he's stable, if the MAP goes above 65 and the patient's at 85 MAP and like it's 610, I'm not gonna titrate it.
Yeah.
Because I could drop the level by like 2.5 mics or just a little bit. Sometimes even one mic and makes a giant difference. And your patient now has hypotension and you gotta mess around with them. So then you kind of get behind your work and you get stuck charting late and it's just a pain in the ass.
Or you have a patient on a Precedex drip and you decide to titrate so the patient is a little bit more awake. You're charting RAS go -2, but your RAS is like -3. You want to wake the patient up a little bit. 6-15 hits, but within that half an hour, patient is a little bit more awake, probably pulls a couple IVs. You got some blood on. Now you're changing the sheets. That happened too many times. Yeah. And that leads to the next point. Like when it comes to end of shift, like tidy up your room, dedicate that last half an hour to make sure your outputs are documented, all your drains are emptied, JPs, NG tubes, clean out the suction, the chest tube intake and outputs, turning your patient. Sometimes you might deal with that 7:30 o'clock med. You might have to kind of chart it back to 6:45 to give it, or you might push it to 8 depending on what's going on.
Yeah.
I hate a bad pharmacy usually where you always have to request meds. And the last thing is like I feel like 7 p.m. and 7 a.m. is like this golden hour that yes, you're supposed to tidy up the room, but things are always happening. Patient always wants to use the commode, last minute bowel movements. The lunch tray comes, you're setting that up. You have to give insulin, AccuChecks, like that end of shift is never smooth. Sometimes you can make it, but it's just there's a lot going on always.
Yeah, for some reason it's just that time. It's weird, and people will understand. Nurses will understand this golden hour. Like
last minute RTs,
yeah, of course. And also you want to make sure that all your drips are in check. So you want to order the next round of drips. So if your maybe propofol is halfway full and you don't have an Epixis, or let's say probably fentanyl, I guess in certain cases amio, if it's like 100 mLs left and medication is going at like 25 an hour, so it's 4 hours left, just order it. Even though there's still 4 hours left of it, just still order it. That way they don't have to order it when they get on shift because it's busy in the beginning. And sometimes pharmacy takes a little bit of time to get the medication and you don't want it to run dry. You rather have it just sit there like prior to it running out. That way they could just hang it at 10 p.m. if they're coming at 6.
Yeah, and those are like one of the pet peeves that we covered at one of the episodes is like
lines
tubing's running dry. Yes, and I had that happen just 2 days ago. It was a new nurse that started. I know that because I asked him on night shift, and he set up the Cardine to literally run dry. Like he set it to 500 mLs, and the tubing like went past the chamber where I had to take it out of the cassette and back prime it.
Damn, that's annoying.
Yes, it is.
Yeah, it's every nurse's pet peeve. Because imagine if Matt didn't have the time to hang a new one, or pharmacy delayed, or guess what, somehow there's a shortage, or a pharmacy said they tubed it, but they didn't, and it's host of problems and tubing's dry. So always put like 20 milliliters less of the medication that you're instilling. So if your medication has 100 ml, set it to 80. Right, just like that. That way, at least it alarms and you have some time to order it.
Yeah, and good perspective is if you have a patient with a brain bleed that just had surgery, you're trying to make the systolics under 140. Your drip runs dry. Now you have like half an hour to 45 minutes of delay. Your patient's hypertensive. That's not looking good. That's not safe for the patient.
Yeah, and it's just annoying. You're just adding stress on the next shift, and you're already setting somebody up for failure.
Right. Plus, it's just like the constant troubleshooting, which is annoying. So just avoid that by being proactive in that aspect. So the next thing when it comes to end of shift is giving a good end of shift report. And I feel like this is critical because if you miss specific things that are important, things could happen, errors could happen. Just like at our one facility we worked at, the whole potassium case, right? They missed it in report. No one discontinued the orders. No one checked the lab values. They hung potassium IV again. there was a cardiovascular event, patient passed away. That's an issue. So,
Or even in Oakland where somebody hooked up some tube feed to a central line.
yeah.
It's wild.
And that's why I'm not a fan of the 8-hour shifts, because the continuity of care is bad. You're not going to give a report to the same nurse. So sometimes as a shitty nurse, you're going to feel less obligated to do something or say something because you're not going to see that nurse again.
Right.
Like that stuff happens. It's annoying.
Yeah, good point.
So when you're going and giving a nurse to nurse end of shift report, this is how I give my report, and usually you're the same way. So I have my report. I start with the name, the age, code status, are you a full code DNR, partial, maybe you're a DNI, isolation precautions. We go over diet, allergies, the patient's admitting diagnosis, and I usually always give the date of when the patient arrived. Then I go into like relevant history or that diagnoses during this time. The consultations with doctors on a case. Sometimes I'll give the reasons why. And then I go into like the chain of events. So, patient came in for a shortness of breath. This day he got a chest x-ray, or he got a CT scan on this day. What are the chronological events that led the patient to where he is today? And then I go through the review of systems. You have your regular, neurological, respiratory, cardiovascular, GI, GU, skin, wounds, AccuChecks. You go over line access, drips, medications, lab values. Then you go into microbiology, antibiotics, plan of care, status, family, and maybe some gossip at the end.
Yeah,
that's a wrap.
Yeah, that's legit. That's legit how it should go. Like that's from A to Z, right there, head to toe, everything in that order. So you always want to start with the history, why the patient's there, a little bit of a story, move on to the systems. You can always give some backstory in that, your I's and O's, and then you can always break it down a little further with the diet, sugars, like Matt said. Yeah. And it's just a whole cascade. But once you get it down, it just flows.
Yeah, and I think this is the best way to give it, because you paint the big picture of what's going on in the whole story, and then you go into the chain of events and the review of assessments, and then the nurses are going to know what specific assessments they should focus on in the report, because they know what's going on with the patient. Yeah. And some nurses are all over the place, and you'll get better over time with this. It doesn't happen overnight. Just like you mentioned, you get tips from older nurses, and you keep creating and crafting your end of shift report, so it's better and better.
Yeah, it's always good to have like a little synopsis at the end of the highlights and exactly what you did that day. So tell them, high sodium, so you added 0.9, or you added saline flushes to the patient's G tube. Like, tell them what you did that day that changed the patient's status, or that changed from the day prior or the night prior.
Yeah,
just be specific in that, because a lot of things that you do on days has almost like a larger effect than on nights, because you don't do too aggressive treatment on nights unless you really have to intervene with something.
Yeah.
You kind of leave that towards the day if you could wait, because there's more support, and if something were to happen, you got more support there, and it's safer outcomes, essentially.
You make a very good point. And, when you give a report, you also could tell how good the nurse is and what's going to happen also. Because it's really hard. I feel like in healthcare, there's that transition that I always mention, where you go from task to actually holistically taking care of the patient and being able to dictate care and tell the physician what you need more from from yourself to be a better advocate for the patient.
Yeah, for sure. And some tips that we could probably give to you how to better your report is,
well, this is for giving notes.
We'll give notes. Then I would say for sure be more objective than subjective, because objectivity is like the main focus in a hospital in acute care. And subjectivity isn't really necessarily in majority of the time, but you can just add it for a little bit of flavor when you're having a conversation. But be more objective than subjective if you're going to give a report, or how to improve your report, or even when you're doing notes and just things like that. Because sometimes you have these nurses and you know what kind of report it's going to be based on how the nurse gives a report. And a lot of times there's a lot of subjective information that is just opinionated, and little bits of gossip and what they talk with the family, and it doesn't really necessarily be needed to be stated. It's just there to just use as talking points.
That's why I'm never a fan of reading nursing notes. When I always start my shift, I always look at in my specific field, I always look at the intensivist note, and that gives me the synopsis of what's going on, what I should be expecting, how we're treating this patient in every single little disease process. and that's all I need. And yeah, you're right, because sometimes reading a nurse's note, it's not objective, it's subjective, and I don't need to hear that extra jargon, you know.
My favorite part is when physicians have a note and have the dates listed of when a patient came into ICU. So it says like 6:15 patient intubated, 6:16 fluids added for this, 6:18 patient stable, and like next day on it says patient deconditioned. So we did this and that, and it goes day by day, because then it gives you like a really good piece of information, especially if it's your first time with that patient and the patient's been there for a week. Not all physicians do that in their notes, but I love when they do it. Like up top right there so you can read it. You know exactly what's going on day for day. And that's always so beneficial.
Yeah.
And I literally just copy that down and I give that to my nursing report.
And that's all you need for a good report. Another tip when it comes to giving or creating a great note is just read other notes from veterans. Usually they know how to differentiate like facts and provide great insight. And they also could be great mentors. You know, if you don't know how to give a great report, look up to other people, ask your charge, ask another, fellow nurse, and read notes and just take insight.
Yeah, be specific to the event that happened. So let's say you transfer a patient, it could be something simple like patient's stable from 0800 to 1200, discharge orders received at 12:30, patient transferred out of the unit 12:45. Because sometimes they want you to write an end of shift report or like a transfer note or whatever they want to call it. So something simple like that, to the point.
Yeah.
You don't really have to say what you did or anything. Just say the patient was stable, because all that matters, and you got the orders and you sent them out.
Yeah, and usually in like the EMR, you're already charting, hey, RT happened this time. You already called your physician. This was a critical value that you report. So it's like the note is, I feel like it only increases liability.
Yeah, it does.
And this is going into the next point, which is give details instead of like conversations, right? The worst thing you can do is include a dialogue that you had about the patient between you and the physician. There's no need. Now that you heard our previous podcast episode, the progress notes are used in legal issues, right? In malpractice lawsuits. And a patient could access that information now. So there's no need to be writing gossip, writing extra stuff. You're already charting, it's already there. There's no need to double up your charting that could slip in the cracks and cause an issue for you down the line.
Yeah. If you want some benefit of writing a note, then don't make it a story. Make it straight to the point about an event. It shouldn't be a story, it should just be an event. Patient became hypotensive, called Dr. Hussein, physician order Levofed at 5 mics an hour to start.
Yeah.
Patient blood pressure improved.
Or
we'll titrate accordingly. That's it. You just describe the event. That's it. It's not. You're not giving an opinion on why the patient became hypotensive.
Very objective.
Just straight to the point. What happened? That's it. Nothing extra. No thoughts. No emotions. Not what you think should have been done. Not why you think the patient is hypotensive. Nothing. Not what the family said. Just leave it straight to the event, and that's it. Short and sweet, to the point. Straight business.
I feel like a lot of nurses also include medications that were like given, which is okay, but also like listing out orders and stuff like that. That's the doctor's responsibility to update progress notes on their behalf. That's their responsibility. First of all, putting in orders. So there's no need to be, saying how blood pressure is this and metoprolol, just be very detailed. Patient tolerated hemodialysis fine, 2 liters removed, vital signs stable, VSS, continue to monitor. My OG line right there.
Right, VSS, yeah. And I don't really write that much notes. I don't think it's really necessary unless there's some reason or form where you can't put it in the chart somewhere.
Ever since C19 happened, they weren't checking as much. I stopped doing notes. No one has said anything, and I'm good. I haven't done it since. My charting is meticulous, and that's all that matters. And I give great patient care. Nobody's on my ass. I'm happy they're happy.
Yeah. Like I said, even back in Chicago, I don't write so much notes. Like I said, if it can be charted on in the regular chart, there's no reason for me to write a note. If something were to happen, and hey, whatever is in the chart, I did write a few notes in the past because there's situations where I couldn't figure out what I charted, and I would do a note.
Yeah.
And I knew there's a way to access it, but I couldn't figure it out. And my superiors or supervisors didn't know how to access it either, so I would just put a note. And they told me, hey, just put a note.
Yeah, and
you're covered.
And just like you mentioned, and if I were to do it or they're making you do it, make it short, brief, just like we always have said and say during this episode. 1 to 2 sentences, you're good to go.
Yeah.
So if you guys enjoyed this episode, we talked about everything end of shift duty wise, how to give a good report, how to tidy up your room, what to do last minute, and how to give a good report and some solid notes.
Yep. Have a good day, guys.
Peace.
Bye-bye.